Hello and welcome back, everybody, to the Patient First podcast. I'm your host, Dr. Bryan Laskin. And as always, I am excited that you are here. And I'm very excited that we have a phenomenal guest today on the Patient First podcast. Dr. Mohammad Kamal is a renowned pathologist, CEO, and founder of OMNIPathology Lab. With an impressive track record and sought after international educator, Dr. Kamal has shared his expertise with audiences worldwide. His commitment to advancing the field of pathology and his passion for education have earned him a well-deserved reputation as a trusted authority. Dr. Kamal, may be the first pathologist that we have here on the Patient First podcast. It's been too long. So thank you for being here.
Dr. Laskin, first of all, thank you so much for having me as a guest on your show. And it's quite an honor to be the first pathologist to be on that show. And I'm really excited to talking to you and to your audience.
Well, and for the pathologists that I forgot to have been on the podcast, I apologize. I apologize if you're listening. It's been a while. So I have very poor memory. However, how did you get into pathology in the first place?
And I have an out for you also, because I
yeah.
am for sure the first GI pathologist to be on your show. There's no way you had a GI pathologist before me. So
Well, I'll take it. I'll take that out. Thank you.
All right. So I got into pathology. I was born in Washington, D.C. I grew up in Egypt. I went to medical school in Cairo University. I always like to mention my alma mater. I think it's really important, especially when it's a school like Cairo University, which I'm very proud to have been part of and a graduate of. So I finished. I'm a citizen by birth. So coming to America was really a very easy decision. I wanted to come and pursue my medical career in the United States. So I came in and I started doing research. And my research was in medical diagnostics. And although my interest in the beginning of my medical school was into cardiology, when I did this research, I became a much better candidate for pathology programs for residencies. And I got into pathology residency, finished my training at Harbor UCLA. And then I went on and did a fellowship in GI pathology at UCLA. And from there, I went out and I started practicing. And throughout my postgraduate career, I have developed from every place I went to, developed an interest in enhancing quality of everything that we do. And one of the things that I noticed from the beginning is that most pathologists do not have direct contact with patients. And my goal was to always highlight the importance of reminding pathologists that there is a patient behind every slide you read. So, and for the audience, the pathologist is a doctor specialized in laboratory medicine. And in my field, I get tissue that is removed from patients through biopsies or surgical procedures. And the specimen comes to the lab, gets chemical processing, and then finally it's cut thin slices on a glass slide. And then I examine that under the microscope and I render a diagnosis.
Well, thank you for the background, and it illuminated a few commonalities that we have. Number one, I was going to be a cardiologist too. However, I never made it to medical school because I went on rounds with some family members that are cardiologists and determined that was not for me,
Right.
and I ended up being a dentist. Number two, I'm actually this week I'm giving a presentation for the UCLA Dental School, which I have at the same time every year the last few years, which is a phenomenal organization, and that's great. But here we are. You're a GI pathologist. I'm a dentist who are also talking on a podcast about putting patients first, right? And beyond, attaching a human to those samples that you have, which I believe is a phenomenal perspective. There's this overarching trend that I think is slowly emerging, and I don't think it's moving as fast as most people would expect or want who believe in this connection, the oral systemic connection, medical dental integration. And I know that you've done a lot of work in this area. So could you talk a little bit about what you're seeing and what you're working on?
Yes. So what one of the things that I've always wondered, and I started to wonder this lately. So as a GI pathologist, most of my clients are gastroenterologists. But also my lab has been also involved in addition to doing GI pathology, we're doing GYN pathology, and that got us into testing, molecular testing for STIs, sexually transmitted infections like HPV, chlamydia, gonorrhea, and different things that are normally tests are run on the pap smear that is done on the cervical pap. So at one point we started to get questions from practitioners about an oral or oropharyngeal HPV testing because we're doing the HPV on the cervical canal, but cervical cancer is not the only HPV related cancer. Throat cancer is HPV related, anal cancer is HPV related. So we started getting questions about that. And at one point, I wondered if, I started doing research and I found that throat cancer, HPV related throat cancer, is on the rise, which is opposite to cervical cancer. Cervical cancer cases are
Mm.
declining. So we said, okay, why don't we develop an oropharyngeal swab for throat cancer, and an oropharyngeal swab for HPV because you want to identify the patients that have HPV infection, right? So as I was thinking about it, I said, well, who has the best access to patients' throats? It's dentists. I mean, ENT doctors. You can live your entire life without seeing an ENT doctor once. So, and if we wait for the patients to see their ENT doctors, then this is never going to happen, or it will happen for a small minority of patients. But you have dentists that are looking at patients once or twice a year for regular cleaning and regular dental routine work, and then the patient is sitting there with their mouth open, and you have access to the throat. Then also I noticed that when I go to my dentist, my dental hygienist, she's doing palpation of my neck. She's pulling my tongue. She's looking on the sides. So she is also looking and screening for oral cancer. So I said, well,
100%.
yeah, I said, well, then that is the test that needs to be offered there. And then as I was doing that research, I was amazed to see that there is a trend in dentistry linking dental and oral health with overall health and all of this oral systemic link. And then the next question came to me is like, why the heck my GI pathology training did not have oral pathology? The mouth is the beginning of this digestive system, right? And I started to really get an interest in oral pathology. I'm not gonna claim to be an oral pathologist or an expert in oral pathology, but I think I know enough to basically diagnose the cases, and the ones that I know that they're out of my league, I refer them to my expert oral pathologist. But this is how this whole thing linked, and this is probably why you and I are talking today.
Well, and another commonality that we have, neither one of us are specialists in oral pathology. So we've got that in common too. Now,
Yeah.
now I believe so. I've been doing a lot and thinking a lot and working a lot. So we work in, my core company, Tooth Apps, is solving the problem of data exchange, interoperability, data accessibility. And when we're talking about that, inevitably we talk a lot about the medical dental interoperability, EMR, EDR. I'm getting to
Yeah.
kind of what
Yeah.
we're talking about. But there's some trends in the industry. Number one, people that are ignoring this completely, which I think you and I both are on the have the perspective that that's wrong, and we can do more for our patients in this category. There's other people that think that medicine and dentistry should be converging and merging together to be one. I'm not in that camp either. However,
Mm.
what you said, I totally agree with. Many patients see dentists that don't see a physician. So, as dentists, we can do screenings in the dental chair for systemic issues where then we can refer them to our medical
Right.
colleagues.
Right.
And that doesn't need we don't need to be specialists
Yeah.
in HPV treatment. We just need to know how and when to screen.
Right.
And similarly, on the medical side, physicians could, if they're looking at a patient's mouth, just just briefly be aware of the oral issues that they could refer to a dentist,
Right.
and then let's make our systems easy to be able to refer back and forth and to
Right.
screen, particularly in the dental practice. I would view our responsibility to our patients to do screenings. unfortunately, unlike your hygienist, some hygienists aren't even looking at the side of the tongue. So absolutely, that's a standard of care today. But let's
Right.
work towards a standard of care where we're doing screenings for patients in the dental chair. Do you
Yeah.
agree with that?
Completely. I completely, fully agree with that. I wanted to tell you something that I've done things in pathology where, you have a sample and we do, just morphology, look under the microscope, make a diagnosis. And then there's another level you do something called immunohistochemistry staining, where you can identify cells of unknown origin by staining them with various antibodies to identify what kind of cancer, what kind of cell this is. And based on that, you make a diagnosis. And then there is another level of molecular testing. And I use that term. I said every time I have a sample, I want to maximize the diagnostic potential of that sample, and every additional test can give me additional information. It's the same approach when you think about the patient's visit to the dentist. This is a healthcare encounter, or an encounter with a healthcare provider, and we want to maximize the potential of that visit. And if you have a cancer that is HPV related and rising, and nobody knows when they get it, right? It just hits you. We don't know. We know the risk factors, of course. Okay, the risk factors of HPV would be multiple sexual partners and lowered immunity. Smoking can cause that. There are so many risk factors. But if we could identify a test with a test now, somebody who's positive for throat HPV, that doesn't automatically mean that this patient has cancer, but it means that this patient needs to be followed up, maybe needs to be retested. And then if this patient is identified as having persistent HPV infection, then maybe this is the patient that can get additional. And I'm not saying that it ends with HPV testing. HPV is just the beginning. And then once you identify these patients, I'm 100% sure that there will be in the future additional testing that can identify patients that are in a precancerous phase, or a patient that is likely to develop it because they have persistent infection. So, but that is an opportunity that needs to be taken advantage of when you have a patient, and when you have a test, and when we have the knowledge and educate the patients and the healthcare provider.
So when would you say, how often and how should everybody be screened, or and
So
if so when and how often?
so that is a great question, and I'm just going to start by saying that in healthcare we have guidelines. Unfortunately, we don't have guidelines for everything. The absence of guidelines doesn't mean that we as healthcare providers should sit and wait for them to descend upon us, right? So we have
I
to be proactive.
I could not agree more. I think the enemy, and in the work that I do in interoperability and standards, this comes across all the time, where everybody's looking for like all of the questions to be answered before we do anything. And I'm like,
Yes.
let's just make sure that let's do something that makes sense, more sense tomorrow than what we're doing today. Right. And I agree with you. If there isn't protocols made for HPV testing, who, when, how, well, how is we probably you probably have down, but but so in the absence of this idealized study that shows who should be tested and when, do
Right.
you have, I mean, you probably have, you might not be an oral pathologist expert, but you're probably the best person who's either speaking or talking or listening on this podcast about HPV testing. So
Right.
do you have thoughts regarding on who and
So
when?
yeah. So I will start with facts. One is multiple sexual partners, oral and genital sexual partners, is a high risk for having HPV. Anyone with reduced immunity is likely to have HPV, and that could be a diabetic, could be somebody on chemotherapy, somebody with acquired immune deficiency. Smokers or heavy smokers also are at risk of developing HPV, because there is a local effect of smoking on the throat. So at least we have those as recognizable risk factors. Okay. Another fact is HPV or majority of HPV infections resolve on their own. But that's not unique to the throat. Cervical HPV also resolves on its own. However, you never hear anyone making any argument that we shouldn't really test cervical pap smears for HPV. It's get tested. In fact, there is a movement towards just limiting the screening for HPV only, HPV testing only. So because of that, the third fact would be that persistent HPV infection is linked to the development of cancer. That's the same in the cervical, anal, and throat. So with those three facts, I think a reasonable approach is you get the patient, you take history, and if a patient has, and I know that this is difficult today to talk about sexual practices in a dental office, but the time will come where we will be able to broach that subject without any problem, because we're going to be palpating necks and educating the patients that, the presentation of throat cancer today, the first presentation is a metastatic lymph node. That's why we're palpating your neck. And then once we do this, then we can talk about HPV infection and we can talk about sexual practice. So we take good history, we identify the patient's social practices and all of these items. Then you test the patient. And if the patient is positive, then we tell the patient, it doesn't mean you have cancer. It means that you need to be rescreened because it could resolve on its own. So retesting in 6 to 12 months is reasonable. This is a screening test. This is like a COVID test, right? So it's not expensive. It's not invasive. It's not difficult. And then if after 2 or 3 times of persistent infection or positivity, then we can say, you know what, there's a concern here that you could have persistent HPV infection. Let's refer you to an ENT doctor. So that's a reasonable approach, and it's not inexpensive and it's not aggressive. Now, bear in mind, there may be additional testing down the road in the future will be available to identify that we're testing for 14 high-risk HPV. But there's also further classification to determine whether this HPV infection, is it integrated or episomal? There's like a molecular genomic further classification that could be done. I don't think we have the data today, but this is work that can happen in the future. But I think to put a patient into a screening program where he or she get followed up by first the dentist, then referred to an oral surgeon or an ENT doctor. An ENT doctor can do a scope. Today, they're saying that there is no recognizable precursor lesions for throat cancer. Who knows? Maybe when we start screening those patients more and scope them more, then maybe we'll find data about findings that could be linked to early cancer. The whole idea is to detect cancer early. So I tell people, I say, as a pathologist, I'm not in the business of cancer diagnosis. I'm in the business of cancer prevention. That's my field is cancer prevention, because I look at screening samples all the time, and the purpose is preventing cancer, not just diagnosing it. I see a very small number of cancer cases every day.
Well, I think just as you said, before that you feel your job is to talk about how that tissue sample came from a patient, right?
Right.
I think there's myself and many dentists who have realized that dentistry, the mouth is attached to an actual human being, right? and if you're going to be treating that human being, this makes all the sense in the world.
Yeah.
And those dentists that do sort of treat overall wellness view themselves as the physician of the mouth, let's say.
Yes.
That in my mind, it makes it a little uncomfortable because it means that we're merging medicine and dentistry. And I think that there's good reasons why we want to keep these disciplines a little bit more separate than that, but have exchange of information and connect them. But regardless, would you for those practices that are on board, would it be reasonable to almost present to patients the risk factors and then ask the patient if they would like to be screened?
Yes. Yeah, that is reasonable. And I actually think today, especially after COVID, the average patients is much more educated about health, and especially the younger generations, they are so proactive about their health. And if we take the approach of of providing information and providing education. There is no harm in information. So even if somebody argues today that, what am I going to do with this positive test? I don't see any harm in knowing that somebody has persistent HPV infection. There's no way that this is harmful. And if people say, well, but this is, patients can be concerned, we do this to women every day. Every woman who goes for a pap smear, and if you talk to your circle, they will tell you that yes, we got a positive HPV, and then after 6 months or a year, it went away. I mean, nobody is arguing that we shouldn't be testing for that. And we know that because the positive HPV infection or a persistent infection is linked to cancer. This is a fact, and it's a fact about the cervix and the throat. So we it's our duty to educate our patients. But I agree with you. If you go to the patient and you say, this is what we're screening for, and we don't have to limit this to throat cancer. It's oral and throat cancer. I mean, oral cancer is much easier to detect because you have those lesions. Throat cancer is a little bit tricky because it grows on the tonsils, and the tonsils have crypts, and sometimes the growth is inward, so it's very difficult to see it on the surface. But you could still detect the HPV infection when you swab the oropharynx.
Well, that's great. So for the dentists that are listening, and for people who do want to, I guess if there's people who are listening that feel like they want to be screened, but particularly for the dental practices that are listening, where can they go to find out more information?
So my lab's website, omnipathology.com, we have a page for healthcare providers and a page for patients. So they can go in there, they can watch videos. I have videos, we have a video about the test, we have a video about the swabbing technique. We also have frequently asked questions. So the provider can go on that page, and they can also direct the patients to the patient's page. And it's just like clear, once you go on the website, you find it. We have a lot of educational videos on YouTube. So if you go on YouTube and look up OMNIPathology, you'll find those, and you find lectures that I have given about the test. And we have other interviews and things like that. So there is a wealth of knowledge that, or videos that we are creating today, including, of course, this podcast when it's out, that we want to educate more and more people about this. And we feel that the partnership with the dentists is going to be extremely beneficial to the patients.
I agree completely. And I think that this is, I believe, HPV, throat and oral cancer screening is a key link in the screenings that the dental practice can provide for patients to
Right.
to you know to help elevate not just oral health but overall health. We all know the connections. We should know the connections between overall health and oral health, or maybe that
Right.
the mouth is the gateway
Right.
to overall health. But in this instance, for sure, I mean, it's hard to argue that dentists should not be screening for. I mean, obviously, we have to be screening for oral cancer. This makes it, one step easy and one step more thorough, I'd say. And I would definitely say, if you don't do it, who is, right? So,
Exactly. And if it's not now, when?
mhm,
Right.
exactly.
And another thought that I want to share with your audience is that usually with every innovation, there is like a law of distribution of innovations. And I'm not going to claim that this is an invention. We took the cervical HPV test and we validated it on the oral pharyngeal samples because we think that this is a great way for us to detect those patients. But for every innovation, there is like a 2.5% usually the innovators, and there is like about 13.5% the early adopters. And then there's early majority, about 34% or 35%, and another 34% of the late majority, and then the laggards. So that is going to be the case. And I encourage everyone to be an early adopter and early majority, because that's really where I think this is where the value is going to be for your patients. And I think it's a great legacy for any practice to take part in a detection of a virus that is linked to cancer. Eventually, the day will come where the throat cancer incidence rates will be declining, and I hope that what we do is going to be one component of the solution to that problem.
Yeah, and I'll mirror what you say. and add to it that I believe that going forward, doing systemic screenings for diseases that are outside of the scope of practice of a dentist to be able to make referrals to physicians is going to become a standard over time.
Yeah.
And HPV screening makes all the sense in the world. So check it out. I think for the people, the dentists listening, it's OMNI pathology. Check it out. Thank you so much for being on the podcast and for everything you're doing to help elevate people's systemic health.
Dr. Laskin, thank you so much for the opportunity to speak with you and your audience. I really am honored to be on your show.
Thank you.
Thank you.